We're going to go ahead and get started. It's nice to see all of you in person, and thank you for those joining us online. I'm going to introduce our speaker, Dr. Quyyumi, in just a second, but before we get started, I wanted to read a short piece about our endowed lectureship series today. In 2010, Natalie and Jack Congdon established the Natalie and Jack Congdon Visiting Scholar in Cardiology, which enables the VCU Health Pauley Heart Center to attract a number of talented cardiologists and physicians. After his service in the Army, Jack helped build the family trucking business of Old Dominion Freight Line Incorporated and Old Dominion Truck Leasing Incorporated. Jack was a proud supporter of the Massey Cancer Center and the Pauley Heart Center. Jack and Natalie passed away about 10 years ago. They had 3 children, and their son John continues to support the Pauley Heart Center as a donor and advisory board member. Thank you for attending our Grand Rounds lecture. I'm pleased to introduce to you our speaker, Dr. Arshed Quyyumi. Dr. Quyyumi is currently a tenured professor of medicine in the Division of Cardiology at Emory University School of Medicine, the director of the Emory Clinical Cardiovascular Research Institute, and chair for cardiovascular research. Dr. Quyyumi graduated from Guy's Hospital Medical School in London, and after finishing part of his medicine and cardiology training in London, he completed his fellowship training at Harvard's Massachusetts General Hospital and the National Institutes of Health. He was a senior investigator and director of the Cardiac Catheterization Laboratory at the Cardiology branch of the NIH for several years before arriving at Emory. His investigative work over the last 25 years has been on clinical and translational research in vascular biology, progenitor cells and angiogenesis, biomarkers, health disparities, impact of stress on cardiovascular risk, and precision cardiovascular medicine. He has performed seminal studies investigating mechanisms of myocardial ischemia, including silent ischemia and ischemia provoked by psychological stress. And he has successfully published over 500 manuscripts in peer-reviewed journals and has amassed over 120,000 citations. Clearly, a prolific researcher and investigator, it is our pleasure to welcome Dr. Quyyumi and his expertise on the topic of precision in management of stable coronary artery disease. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk or for those of you in person. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and on this screen here, and at the end of the presentation to 804-625-4041. I'll now turn it over to Dr. Quyyumi.
Thank you, everyone. And thanks for the invitation. It's a real honor and a privilege to be here. I hope that some of what I'm going to talk about is going to be of some use to you immediately, and then a lot of it hopefully in the future, because I'm going to talk about how we might be able to use some precision approaches into how we manage people with coronary artery disease. And much of what I'm going to talk about is going to focus on stuff that work that I and my lab has done perhaps over the last 20 plus years in a variety of different arenas to sort of culminate into what I've put together for you. I'd like to start off by acknowledging a lot of grant support that we've had over the years from the NIH and AHA and so on. And also one of the studies that I'm going to refer to has been funded by Abbott. So I'll start with a standard case of coronary artery disease that I think we see in cardiology practice almost on a daily basis. So he's a 55-year-old black male with a history of hypertension, dyslipidemia, and smoking. You see his values here: blood pressure, not too bad, LDL 110, little low in terms of HDL, glucose intolerance, BMI is up. He's on metoprolol, aspirin, and a statin, low dose. And he's had a history of chest discomfort and exertion, gets an exercise SPECT scan, shows infralateral ischemia, has a cath that shows disease in 2 vessels, and he gets stented. And as he's walking out, he says, what is my risk of having a heart attack or dying from this condition in the future, and what do I have to do to avoid this? What's my risk going forwards? He's obviously been started on standard medical therapy to take care of his risk factors, higher dose of statin and aspirin and dual antiplatelet, etc. And to answer his question, we can look at a database that we've created, and I'll refer back to this over and over again because a lot of the concepts that I'm going to go through are developed in this data set. So you will get familiar with this, but it's called the Emory Cardiovascular Biobank, which has recruited patients that go into the cath lab like this one. They have their blood stored and a bunch of questionnaires that they answer, and then they are followed for events. And when we did that, and this is data referring to 3,000 plus individuals, the database is now almost 1,000 is big, but I'm just showing you part of this data set that has had some of these markers, et cetera, measured that we're going to talk about. This population over 5 years, about 14% will die, and around the same number, maybe 12, 13% will have cardiovascular death or an MI going forward. So 1 in 6, 1 in 7 people will have these events. And and this is a sort of survival curve of these individuals. But they are managed, in the best possible way with guideline-based medical therapy and interventions, et cetera, as needed. The question is that everybody faces this residual risk. And what are some of the ways in which we can determine what kind of curve that this individual is on? Do we have techniques that would allow us to tell who has really good outcome going forwards and who has really bad outcomes and any of the intermediate outcomes? And there are now ways in which we might be able to predict this. In other words, be much more precise about predicting future of individuals with coronary artery disease. And that's what I'm going to talk about. But stepping back in terms of pathophysiology, and I apologize for the simplicity of some of the things I'm going to say for those who are experts in this field, but just to make sure that everybody follows. This is a cartoon of a blood vessel as we age, as an average American, if you like, ages. In fact, this applies to most countries now. So we start off with pristine coronary arteries, for example, and then over time, there is intimal thickening that develops that's hardly visible if you're looking at coronary angiograms. This gets bigger over time, and then there is this real plaque that starts to develop, and it expands over time until it can narrow this coronary arteries severely enough that they may have symptoms of angina, for example. Or even before that happens, the plaque can rupture, cause an acute coronary syndrome, and the presentation would be with a heart attack or unstable angina or even sudden cardiac death. So this is the sort of a natural history of what we think happens with coronary artery disease. The endothelium, which covers the blood vessel, is pristine, but as it becomes dysfunctional, this process appears to start. How do we assess risk early on? Of course, when we are in this part of our lives, we have all these risk factors. Now there is the prevent risk score, Framingham, that developed into ASCVD or cohort equation, et cetera. There are additional risk factors that are being added to it, Lp(a) being the latest one. And then we may actually step beyond just measuring these risk factors and risk scores and even go about looking for coronary calcium to look to see if any of this plaque that gets calcified can be detected early so that preventive therapy can begin. But then later on, once we have people who have established coronary disease, and that's the population that I guess we are discussing today, then the question is who's going to have rupture of their plaques going forward, then damage their heart even more, end up with heart failure or sudden death, et cetera. How much atheroma burden there is, et cetera. So in other words, who is vulnerable and who has otherwise stable coronary artery disease and would live through that. So back again to how we think we have thought over the years how coronary disease develops and progresses. So once again, pristine blood vessel, developing atheroma, then having rupture, presenting at various stages, either with ischemic syndromes or with an MI. And we know that these are driven by these risk factors that we have been measuring now for 50 plus years. And then we develop this atherosclerotic process and these bad events that occur. Now, just to understand that this disease is ubiquitous, most people who are adults will get it. There'll be some atheroma in most of us. It's not like a minority disease. However, most of us will make through life and not have any events associated with this, and this won't be the reason why we will die. Only about 30 to 33% of men and women will have this disease that will lead to these bad events that will kill them. The majority of them will have this in this sort of background state without it having any life-threatening consequences. So clinically, what we've done over the years mostly is to look for obstructive disease. So we've done stress testing, and we have many ways of doing stress testing, looking for obstructive disease, 70+% narrowing of one or more of the coronary arteries, and then we have all these techniques to open up these blood vessels, etc. And the question is, does the presence of ischemia and its eradication with revascularization improve prognosis? There have been many trials, as you know, that have done this. Looked at this. Courage, this is a slide from Courage looking at people with different degrees of ischemia within this Courage trial. However, the amount of ischemia, irrespective of how these people were randomized going forwards through revas versus medical therapy, did not actually differentiate risk. However, the amount of atheroma they had, the degree of atherosclerosis was actually prognostic. Similar results in the ischemia trial, which was selected for people with ischemia to go in, but interventional versus conservative therapy did not change hard outcomes, even though angina was better treated with interventional approaches early on. So the bottom line is that going after ischemia and then treating it, often with interventions, is associated with symptom relief. However, it may not improve prognosis dramatically in individuals. And when people ask us after their procedures, you know, what do you think is going to happen? I'm going to be fine. The answer is no, they still have residual risk. And that is not dependent on how much narrowing they have in their coronary arteries. Now, if you delve deeper into the history of this individual, for example, he says that his father had died at an early age. So we know that there is some genetic influence on this and the susceptibility to the disease and its outcomes. So there is this genetic influence that's been recognized, of course, forever, since we've known that family history is important. And then over the years, our group, but many other groups have looked to see if we had a genetic solution, and that would lead us to better prediction of risk. And back in the GWAS era, which started now almost 18 years ago, when we were involved in the first GWAS, and this data set that I'm referring to actually was created exactly to decipher this genetic influences on coronary artery disease risk. The first polymorphism that was discovered was this 9p21 that added 20%, 22% increased risk of having coronary disease. So when you show this information to clinicians, for example, like each other, so the question is, they say, so what do I do with this? You know, I'm doing what I can. How do you treat? You know, we know how to treat diabetes and so on with all these fancy drugs now, but how do I treat high CRP and high sense troponin level is up or SUPAR is up? What is SUPAR anyway? And what do I do when I find this out? So why should I be measuring these things? So the question is, if you found that out, is it like genomics? You can't really change anything, you know your risk, but then, you know what it is. You might take a vacation if you're on that brown line, and do whatever you wanted to do, write your will. But is it modifiable? So can we do something in order to make the outcomes better? So we used the Barry2D data set, which had blood stored at the beginning, and then after all the interventions were made, people were randomized into revas versus medical therapy, and then they were treated very intensively, smoking cessation, weight loss, apart from getting the LDLs and so on, and glucose is down. And what we found that after a year, all of these biomarkers came down on average. But if you look at what happened to the biomarker risk score, now we only measured 3 out of the 6 that I'm talking about here, so it's not the entire panel. But people who were classified as high risk based on this biomarker risk score, 21 in 5 remained high risk, whereas almost 4 in 5 became low risk. So in other words, all that intensive therapy that was part of BARI-2D, not the revascularization, but the intensity of the medical therapy and behavioral therapy, et cetera, that was involved, actually normalized it in 4 out of 5 people. And in those who started with low risk, most of them remained low risk, but 11% actually switched sides and became high risk. So these are changeable, and you shift sides, and actually treatment optimization of treatment seems to help. And then you'll say, so when they change, do they mean the same thing? So this is the biomarker risk score, low risk score in the first year, good prognosis, high risk score, bad prognosis. But when you remeasured and reclassified people, once again, the 0 and 1 biomarker risk score people are here, and the 2 or 3 positive people are up here. So in other words, it's modifiable and it's predictive. Here's another study looking at this large trial that examined the effects of ezetimibe plus statin versus statin alone. They improve it. And there they measured 4 biomarkers, troponin, BNP, GDF15, and CRP. So a little different from the panel that we're using, but at least 3 out of 4 are the same. And what they found again was that the numbers needed to treat in those people who had a high biomarker risk score, the 20% who had all of these positive, they had the most improvement. Those who had intermediate biomarker risk score, they had some improvement, and those who had low biomarker score had no improvement. In other words, you can direct intensity of therapy at those who had high risk, and you're likely to see the benefit, but treating everybody the same way may not be the right thing to do. So there are 2 aspects to this. Not only are you detecting people who are at a high risk that maybe you can modify their risk, but also you can identify a lot of people who are adequately treated and they have no risk going forwards based on this kind of measurement, and that you don't have to intensify and go after them anymore, as it were. So the BRS is modifiable by guideline-based therapy. People say, my patients are maximally treated. They come to see me. Of course, I've got them on everything that I can possibly have them on. This really isn't going to change my habits because I've got them the best possible way. So when you think of what's actually happening out there, this is 1,500 people, and there are many studies like this. I'm just choosing one of them, who are post-MI. And in this study, they looked at, half of them were followed by cardiology, half by primary care. And they wanted to see how many people were still taking DAPT after 1 year of having a procedure for the MI, and beta blocker or a statin for 3 years, and ACE inhibitor if they had diabetes. And only 36%, meaning 1 in 3 people were properly treated, even based on this very basic kind of criteria. So even though we think we have treated them well, they may not be actually taking, 46% of people don't take their medicines the way they're prescribed. The number is probably a lot higher than that, but at least that's the amount you can detect. So in summary, then the biomarker risk score based on these measures is a powerful and independent and modifiable predictor of adverse events in patients with coronary disease. And subjects with elevation of these biomarkers obtain the most benefit from standard medical therapy, and optimization of medical therapy and lifestyle intervention and risk factor control is associated with decline of these biomarkers, and remeasurement of these biomarkers after a while of institution of optimized risk factor control and medical therapy is also likely to provide important prognostic information. And a decrease in biomarker risk score is indicative of better prognosis. So there's something you can use to not only just measure once, but also to use it as a measure of risk going forwards. So, there'll be an array of these proteins and other metabolites that we will be able to measure. You can see how these pathways have many proteins that different proteomic risk scores that are being developed have different combinations of these because they're looking down these different pathways, which are all additive in terms of ultimate risk that we face. And that using these kinds of technique going forwards, if they can be made affordable, will change perhaps our somewhat imprecise management of people to being more precise for their risk. So in order to address this, we started this study, which is a pilot called the Precision CAD trial, where our contention is that the conventional approach uses similar medications, similar doses in all patients with coronary disease. And that this precision approach, which will add a biomarker risk score, would allow us to identify those people who are, with that approach, low risk and should be managed that way, but also identify those at high risk where you could intervene and perhaps reduce their risk. So we're doing this using just 4 biomarkers because the C-statistic area under the curve is similar to 6 and is cheaper and more easy to do, basically, just to make it more affordable. 3 of these 4, of course, are clinically available except for SUPAR. And the idea is that we will select people who actually don't have heart failure or anything, but have coronary disease. We'll measure this. Those who have 1 or more biomarkers elevated, they'll be randomized into optimization or usual care, basically. And we have a scenario of what optimization means in terms of how they will be optimized. And it's listed here, but I won't go through this. But there's straightforward things like, if the LDL is not down, we'll add ezetimibe and PCSK9s, et cetera, and so it goes. And then, of course, we have some other things now with low-dose anticoagulant, omega-3s, colchicine, et cetera, that have been that increases the armamentarium of what one can do. Of course, with the diabetics and obese people, we have the SGLT2 and GLP-1s, which can now be added as well. So as we move forwards into this precision medicine kind of approach of treating coronary disease, we talked a little bit about genomics. There are other technologies that we have and others have been looking at. Metabolomics, this is a way of measuring all the metabolites in our circulation. Anurag actually is the first author of this paper where we looked at metabolomic risk score in this subset of the biobank population that came up with this method of using metabolites to measure risk. And in another study, we looked at gene expression profiles, circulating leukocytes, and can get very nice discrimination of risk based on even gene expression of leukocytes, et cetera. So, and I think all of this illustrates to us that there are technologies out there that allow us to discriminate risk better and perhaps even provide pathways that will allow for drug development, et cetera, that will be more useful. So genomics has its utility, prediction probably useful early in life. Measurements of subclinical disease is hard. So obviously it's not done clinically, but CT calcium scores widely used to predict risk in the asymptomatic people who don't know they have coronary disease. This novel biomarker approach that I've talked a little bit about based on our work and others, based on proteins, probably easier to measure and implement, and it's modifiable and predictive going forwards. And then there are these omic techniques that are still being studied, which will allow us to discover new pathways, perhaps even, where we can understand better the pathophysiology of progression of disease, not just the development of disease, but what makes it progress. And then perhaps have better therapeutic strategies built on that. So in finishing, I just want to talk about this one thing. What we have, and this is about regenerative medicine. And because what we have talked about so far are all these factors that lead to damage of our blood vessels, injury, right? Whether it's grossly talking about diabetes or hypertension or hypercholesterolemia is damaging our blood vessels. And then all of these biomarkers are a reflection of that kind of injury. But when all of this happens, the endothelial injury that leads to subclinical disease and clinical disease, what we also have simultaneously is an endogenous repair and regenerative system that is continuously repairing the damage that's occurring. It's so-called. So we have stem cells, both resident and in our bone marrow, that allow for this process to occur. So once you damage your vascular endothelium, for example, it doesn't sort of die forever, it gets replaced. And some of these tissues get replaced a lot faster than others, like the endothelial cells. Myocardial cell takes 40 years to replace and so on. So there is a different cycle for these things. But nevertheless, there is this damage and repair that is going on in us constantly. And we can study the bone marrow ability to produce these stem cells, but these are progenitor cells. That means they are sort of down the lineage by measuring circulating CD34 positive cells within the monocyte population. So, or mononuclear cell population. So they express CD34, mainly enriched for hematopoietic stem cells. But then if they're expressing VEGF receptor, they are thought to be progenitors for endothelial cells. So we using FACS analysis, we are able to measure these circulating cells. They are very infrequent in their numbers. But the bottom line is that people who had good numbers of circulating cells, which is on the blue line, their prognosis was almost threefold better than people who had run out of these cells. And I'm sort of cutting to the chase. I can give an hour's talk on this stuff, but the bottom line is that regenerative capacity as measured by these cells, because we're measuring circulating progenitors, which is reflecting our bone marrow's ability to generate these. And presumably they're also reflecting cellular repair mechanisms. If you have the system active, despite the disease that these are all people with coronary disease, you have much better prognosis than if you've run out of these cells. So this is independent of all these biomarkers that we talked about, all the risk factors that we talked about. And so what it's telling us is that there is more to be learned, number one. And the second is that we have damage and we have repair. And that every time we damage, we also repair. And if our repairability is impaired, then we're also going to have bad prognosis. And to be really predictive, we will also have to encapsulate a study of this pathway within our paradigm. So the idea is that we have damage, we have repair, and it's the balance between the two that determines outcomes. And this clinically is very easily understandable because you have many patients who are smoking, for example, who come and say, my grandfather smoked till he was 92. Nothing happened to him. Why are you telling me to stop smoking? And especially in this area, and because the grandfather probably had a very good reparative system. So he could damage, but he could repair. And not everybody has that privilege. So in terms of precision then, this is my last slide. What we've learned is that there are all these factors, social determinants, psychological determinants, even down to the neighborhood, that we need to encapsulate in our risk assessment. These are actually independent of these biomarkers as well. So these things really matter. And then cognitive stuff, which I didn't talk about, how we diet, exercise, our risk scores, and then adding to it some biomarker risk score for this value that it's such a good discriminator of risk, can come up with this composite risk score. And as you can see, you can have all of this done by your patient before you see them. So you can have something like this presented to you as they walk in. And rather than having to sit there and sift through this, because there's no way of us in our brains integrating risk. And none of this, notice, has anything to do with how much coronary narrowing you have, because that is actually not predictive. So lots of people over the years who have helped create this data set and funding agencies. Thank you very much for your attention.
We'll now take any questions from the audience, and I believe there's several in the chat as well.
Arshed, thank you for such a wonderful talk. Briefly, you mentioned exercise. Have you looked at two things? One, how moderate intensity exercise, or actually just being active during the day, impacts these biomarkers, and then secondly, the reparative process, the production from the bone marrow of those progenitor cells?
That's a great question, and to be honest, we haven't done that in terms of the biomarker risk score. It would require a we've looked at some. I mean, this is the way I'm going to answer this. It's the repair question is actually a bit more complex than I made it out to be honest. That's why I didn't want to kind of. As we develop risk factors, so you don't have disease and you are still, say, around 40, 50, and you've got some hypertension or whatever, the number of circulating progenitor cells go up. So it's telling you that you are requiring this extra reparative mechanism to be activated so as to dampen down the injury you're causing from this. So when we looked at some of these interventions in that sort of age group, we found that their progenitor cell levels actually came down with improvement of their diet from the usual American diet to Mediterranean diet and improving activity, although these were not dissected as what you're asking. But overall, the idea is that we activate the system, we use them up early in life so that later in life you run out of them. You know, it's thought that we have certain number of stem cells and then you use them up. And this is, for example, in people who have muscular dystrophy where your myocytes are dying because of this abnormality that's inherited. There are these stem cells that are activated, they keep replacing them. At the age of 20, you run out of them. And that's when the weakness starts and you die. And that's that process, but obviously it's much more slow and so as we use them up, we have actually higher number of cells and you can passivate them as it were. You can get that down by using these hygienic measures. So it all works, you know, as you would think, but it's a bit more complicated. People say, oh, your cell count is high, you must be very healthy, but actually having it too high is showing you that you are actually not healthy. So it's all, and that makes it a very difficult test to work with, most of us. So anyway, that's, but for the protein risk scores, we haven't studied them, although, you know, people have done lots of studies with CRP and so on to show the improvement in inflammation with diet and exercise. I presume some of this applies to these other biomarkers as well.
Thank you.
There are other ways people are looking at the risk visually with intravascular imaging and predicting plaques that look at risk and so forth. And now a lot of non-invasive CTs and MRIs and so forth. Have you looked at matching these biomarkers to the imaging studies? Because the imaging studies may be a quicker, I don't know if it's less expensive, you know, where does this fit?
That's a great question, and that's our grant application. So I don't know the answer to that.
Okay.
But I think that's what we are trying to see is whether this is reflecting vulnerable plaque. And I would argue that this would be a lot easier way of judging your vulnerability rather than keep getting dye every now and then and seeing, because the vulnerability of plaque actually fluctuates, as you know. This plaque looks active. Next time you look, the other one does, but this one looks normal and so on. So it's a very moving target. And so, and this is reflected in these biomarkers as well. They don't remain rock solid. You can see how you can actually modulate them. You would think that a simple blood test would be the way to go, especially if you can do this as a multiplexed, you know, a single test. You get a number. It'll be a lot easier to be used clinically. But I'm imagining that that's what it's reflecting is the activated plaques that you have.
Thank you.
I was curious. I think your talk is very timely. We're readily identifying a lot of the deficiencies of our current risk assessment. The lifestyle modifications you mentioned are really a cornerstone of your biomarker risk score and the improvements. Anything in particular with lifestyle modifications that you find particularly impactful for the patients, or is it just as a whole, or just identifying low-hanging fruit like smoking cessation or diabetes management, diet?
The way we are, you saw the precision CAD trial that I briefly explained that we are trying to do. We are doing it as a multi-approach model. We're not kind of targeting one thing or the other. It's not supposed to be a single drug intervention or a single lifestyle intervention. It's like whatever this person needs will be modified. So we're not going to be able to answer that question that well. But what we did do in the other data set that I showed you, where we had the opportunity in Barry2D to measure baseline biomarkers, and after 1 year, we tried to see what was it that was driving the reduction in CRP and the reduction in heat shock proteins and this and that. But it wasn't really, it was very hard because, the blood pressure was coming down and LDL and the glucose, or just the weight was coming down. You have to do this kind of a multivariate analysis, and it gives you very strange results.
Sure.
Like the best predictor of CRP reduction was reduction in blood pressure, for example. And that's not what you would have said, right? You would have thought it was the reduction in LDL that would be the best predictor. So I'm not sure. I don't know how reliable that kind of information is. So we put all of that in the paper because everybody wants to know, what do I do for this biomarker? What intervention would change that? But we've, at least so far, only been doing it in this sort of an approach where you do everything and not just one thing at a time. But I think over time, we will kind of be able to do just one intervention and see what the effect of that was, and figure out what is best for that each one of these pathways that's being activated, that's being reflected by the biomarkers.
Okay. Thank you. I believe there was at least one question in the chat. I think we have it pulled up. Yeah. So one question is, thank you for another great talk from Brompton to Richmond. Do you have models for coronary artery disease precipitated by COVID infection?
We really haven't systematically looked at that. I'm not even sure how much coronary disease is activated, but people had, at least epidemiologically, from what I'm aware of, it's people have had perhaps more activation of their coronary disease, more events in people who had coronary disease, but it's been really difficult to understand how true that is. A lot of myocarditis, of course, that was associated with COVID. Hard to know, but we certainly haven't studied all of these biomarkers. SUPAR has been studied. SUPAR and CRP. CRP has been predictive in terms of outcomes in people who are hospitalized with COVID, as has SUPAR been. And in fact, there have been some trials to look to see that use of some of the more expensive agents, the antibody treatments, were more effective in people who had elevated SUPAR levels, and that became a kind of a diagnostic test to seek to know which group would benefit from it, but not necessarily from coronary disease, more from lung outcomes. Yes.
One more question. Excellent talk. Similar to what Dr. Hunley was saying, but maybe instead of thinking it from a lifestyle modification perspective, if we're looking at risk, a lot of those biomarkers that you presented that pretend that I'm going to develop subclinical cardiovascular disease, they're significantly influenced by habitual physical activity and cardiorespiratory fitness. Have you looked at that from a risk standpoint, where those where those models were incorporated into that?
Early on when we were working with these oxidative markers and so on, rather than these ones, we examined the effect of being completely healthy and even selected a group of individuals who we found in gyms for healthiness and measured their oxidative stress profiles and as compared to your usual age match group who had risk factors. And they had better numbers, if you like, less oxidized. And that sort of strengthened our. So for example, I showed you how oxidative stress increases with age on average. Like we get more and more oxidized based on those aminotile measurements. If you are aging, like if you look at the population develops no risk factors over time, over their ages, they actually don't increase their oxidative stress over time. It's only these individuals who have risk factors, which include, lack of exercise and weight, etc. They have this increase. So in other words, and the same is true of the progenitor cell stuff, your regenerative capacity. If you're aging healthily, there is actually no decline in your cells over time. Whereas if you're aging with risk factors, there's this steady decline over time. So it's showing what you're suggesting is the case. But once again, we haven't actually taken people intervened that way and measured everything before and after. Although there are small studies that have looked at each of these biomarkers and have done that.
Dr. Quyyumi, I have a question. Thank you for an informative talk. A couple questions actually. Has the BRS been externally validated or integrated into an EMR at the hospital? And the second question is, how does the BRS perform for special populations such as South Asians?
Great question. So it externally validated. So we have now validated in 3 cohorts. And then, as you know, there are these other protein biomarker risk scores out there in other cohorts as well. The other validation cohort was also a group of people with coronary disease, and it validates. We also looked at it in MESA. It's not published at this moment, so I can just tell you that it validates even in the general population, although the numbers with high biomarker risk score are proportionately much lower in the general population than in this high-risk population of coronary disease. So, however, it means the same thing. If you have high levels, you have worse outcomes from cardiovascular endpoints. In fact, SUPAR is the best marker for renal deterioration after creatinine itself. So even though we get focused with cardiovascular versus lung versus kidney, actually when you get into these processes that these biomarkers are reflecting, they are showing multi-organ dysfunction and deterioration over time, not just cardiovascular. And as you know, these things are all linked. Now we have CKM because people have realized that these are the same disease. They're sort of done, taken care of by different specialists. So in terms of incorporating them into the EMR, that hasn't happened. SUPAR is actually not available clinically, as you know. It is now becoming available in a couple of hospitals around the US. It is a big deal to get a biomarker in the clinic to be used. So the process is there, but it's not actually available. And our healthcare system suffers from same inertia as all other healthcare systems.
We have a few questions left, but we can email them to you because I think we need to wrap up because we're over time.
Thank you.
Thank you.